PODdoctors. I'm Dr. Damien Dauphinee, and I'm here with my partner,
Dr. Raafae Hussain.
And we are going to jump right into Jones fractures, which are a pretty common fracture we see in the office, but one that can be quite complicated. And we'll kind of get into why that's the case.
Yeah, fifth metatarsal fractures, I feel like, are probably the most common metatarsal fracture that we see in office. I mean, would you agree?
That and maybe March fractures, or that second met fracture. Those two are very, very common for different reasons. But this one can have some healing complications and oftentimes requires surgery, and I'm sure we're going to get right into that. But
so what happens? I mean, we have a patient come in. They say, "Doc, my foot's killing me. I think I broke something. I think I hurt something." They'll come, hobbling in, and they'll have pain, swelling, bruising, pain along that lateral prominence, that fifth metatarsal, base, and that little bump on the side of your foot. And
sometimes they feel it snap. Sometimes it just hurts.
Yeah, and interestingly enough, a lot of them will come in and be like, I've been walking on this, and I don't think it's broke because I can walk on it, but what do you think, and we'll go through our little clinical exam. So, we'll see the bruising, the swelling, the pain, the tenderness, and we'll feel around, we'll be touching those sites, the fifth metatarsal base, along the peroneal tendons, because those are commonly injured, the fifth metatarsal shaft, and, there's a lot of things that can go wrong around that little lateral side of your fifth metatarsal, that prominence. A
lot of forces acting on that bone.
Yeah, you have your fifth metatarsal fracture, your avulsion type fracture, your Jones fractures. You have your peroneal enthesiopathy, your insertional peroneal tendonitis, Island's disease or deformity or apophysitis or whatever people are calling it nowadays. You can have os peroneum syndrome,
Sure.
The accessory bone that's in there. You can also chalk that up to a peroneal tendonitis also.
Sure.
But yeah, there's a lot of stuff going on along that lateral column. Cuboid syndrome, I don't know.
Yeah.
That's not too common, but still.
People who've had EPFs, if you've had an endoscopic plantar fasciotomy, you might be developing cuboid syndrome. That os peroneum can irritate the cuboid notch. It could be irritating the tendon. So I've seen that several times. So those come in waves. It's weird. I'll see like 3 or 4 of those in a week and then not see them again for 6 months.
Yeah. It's far in between. I feel like I see like 1 or 2 a year. Nothing too crazy, but like when it comes in, you're like, oh, this is, and you put that little simple pad there, or you go through your orthotics, and
they usually do well.
Yeah, they do.
But these folks are usually in pretty significant pain.
Yeah.
Like this young lady trying to walk here, but if it was just a standard fracture, they're not usually displaced.
No.
So you wouldn't think it would be difficult to heal.
Yeah, and that's the problem with these fractures. If you can see the anatomy right here, you have your peroneal tendons putting traction on that bone there, so it's kind of pulling them apart. So what do? We get our imaging, right? We're suspicious for a fracture, and we'll get some imaging here. So some of these are, and some of these aren't.
Right.
Your Jones fractures.
I was going to say that that bottom larger radiograph is classic. That would get diagnosed as a fracture by maybe an ER physician or primary care doc, and you're looking at that and like, nope.
It's just a super large os peroneum, or os of salianum, depending on where it is.
Essentially, it's a ossification center that never attached to the main bone.
Yeah, children have a multiple ossification centers, but they have a specific ossification center on that little distal tip of that fifth metatarsal base, and if it never attaches or never solidifies to the surrounding bone, it just floats there, and it's inserted in the tendon. Usually, it's something we say secondarily on the tendon.
Sort of a coincidental finding.
Yeah.
And sometimes they cause problems later on in life, but you don't usually see them in kids because there's no reason to X-ray them.
Yeah. So here's a small avulsion fracture, not a Jones fracture, small avulsion fracture off that base. You can tell it's an avulsion because of the jagged edge. If it was smooth and nice and clean, we would think it's an os peroneum or os of salianum. Here is another small avulsion fracture. And we'll go determining, what type of fractures are Jones, what types are avulsions, what are stress, what qualifies as a true Jones fracture. The only true Jones fracture here is this one right here.
Right. Yeah, and that's based on the region of the bone where the fracture lies.
Yeah. So here I got some good pictures of what Jones fractures really are.
Nice.
So your classic Jones fracture, and what we're seeing as far as Jones fractures are the articulating surface between the fifth and fourth. that's typically your sweet spot to where it truly is a Jones fracture.
Mm-hmm.
So here, another one, nice little gapping there, a little wedging type of action, and they demarcate this one really well. That's where your Jones fractures truly lie, and simple.
That one there is kind of right on the edge, but yeah, it's still right. If you look at the articulation with the fourth, that's in the zone.
Yeah. Yep. So, why are Jones fractures so complicated? Why are we going through this? So Jones fractures are known to be at risk for what's called a nonunion. A nonunion happens when the blood supply or the area that needs to heal isn't healing as well, and your bone's trying to push to heal, it's not healing, and it just becomes a chronic fracture, painful, tender, and obviously unstable. So there's different classification systems that we can go through. Not important as far as if you're looking at this as a patient, but if you want us to go into this more clinically, we can go through TORG, we can go through Stewart classification. I think it's fun. I don't think people want me to tell you about classification systems.
They're there. If you want more information on them, you can Google them and find information on them. So it's really it's a way of being able to describe the different versions, but they all tend to add up to healing problems, which is, from a clinical standpoint, the most important thing. So why we become a little more aggressive with this type of fracture.
So generally speaking, when we're talking to patients, we'll be talking about if it's a true Jones fracture, it's an avulsion or tuberosity avulsion fracture, stress fracture, shaft fracture, or head and neck fracture. So this is kind of a general idea of what we're looking at on the x-rays, trying to decide if it's a true Jones fracture. Here is nice because they show the apophysis and the ossifice hiatus.
So that's in a kid.
Yeah, this would be pediatric.
All those other areas where they have growth plates that haven't closed yet.
Yeah. So we said that fifth metatarsal fractures are very common. Here, I pulled up a study that out of 400 metatarsal fractures in 322 patients, I think over 50% of them were fifth metatarsal fractures. Yep. And then, 10% of them are true Jones fractures. Pretty high. And then here's something that I thought was interesting. The most commonly injured body part while walking, 42% is your foot. You'd imagine it'd be your foot, but sure. People injure themselves, walking, stumbling, whatever it might be. But
keeps us in business.
Yeah, and then a general, what we were talking about earlier, that over about 50% of fractures in the metatarsals are most commonly your fifth metatarsal. It's just super high, very common. So what happens? The mechanism of injury. This is the fun biomechanics of what really happens. Typically, up to you. What do you think? Typically, supination type injury. They put pressure on it, and that puts traction, and you get sort of that weird.
It's a combination, but I think that's the position that puts you at risk.
Yeah.
So very common in soccer, very common in basketball.
Basketball. Oh yeah.
Occasionally you'll see them in baseball players, but it's usually in a sliding injury.
Yeah.
Where they're sliding into the base and
and
you just get that tremendous force.
Yeah. So
and the tendon is yanking the bone.
Yeah. So you have that pressure from the ground pushing up towards that fifth metatarsal head that's slightly turned in, right? Supinated, right? When you turn your ankle in, and it pushes up on that fifth metatarsal and it's pushing. Then your peroneal tendons, which are antagonistic to that force, are pulling here, and you get sort of like that.
And they'll fire just based on stretch receptors. Oh, yeah. So it's a very fast feedback loop to help you not break things, but they do it. It does it so violently in some cases that it will break bone. So it's a feedback loop that was probably designed to protect you, but in this case, if you're in the wrong position, it'll actually cause the fracture.
It's that what's that test they do for children when they're like newborns to check if they have their guard sensors, where they lift them up just slightly and they let them go and they flail out.
It's a reflex.
So here's a good depiction of what's going on.
That's nice.
The peroneus brevis, the peroneus tertius, they're pulling and that traction from the pressure that's coming up towards that fifth metatarsal and pushing it dorsomedially. That traction, it's just simple. It's bound to happen. I couldn't find a great picture, but
those are pretty good. Those are pretty descriptive. Yeah. That's nice. That shows the two tendons that are likely involved. Not everybody has a peroneus tertius.
Yeah,
But the peroneus brevis, that little bugger it's a powerful muscle tendon unit, and it's also associated with avulsion fractures in people who have just sprained their ankle and they break off bone because that tendon is literally trying to prevent an ankle fracture.
Very commonly missed. Yeah. I'm glad you said that, because we're looking at big things as far as ankle sprains. We're like, oh yeah, it's a fracture of the fibula, the tibia. It's a lateral ankle tear, and it's very easily missed. Mm-hmm. I feel like I'll catch it on the lateral X-ray sometimes, and I'm like, all right, let's get a DP and a medial oblique, and we'll catch it on the foot. And sometimes patients don't even realize anything happened there.
Because they're hurt so many different areas. Yeah. But yeah, that's one you don't want to miss because of that tendon attachment. It'll just continue to distract the bone if you don't immobilize them. Thankfully, with that type of injury, with an ankle fracture or a bad sprain, you're going to probably immobilize them for a period of time anyway. So you're going to treat both problems. But yeah, you don't want to miss it.
So why Jones fractures are so important. So Jones fractures, like we said, are high risk for non-unions. Depending on who you read, they estimate about 40 to 50% of these are at risk for non-unions that undergo conservative therapy.
Right. Yeah. Right. Those would be those that don't end up going to the operating room to fixate these.
Yeah. And then when surgery, it's like 90%, 99, 95%, something like that.
Success rate.
Yeah. Still not high for surgery, but still, as far as compared to 50%,
right.
Quite an improvement.
Way better.
Yeah.
So I think you and I are both pretty aggressive with these. When we see that fracture in that area, we're going to put a screw across it or a plate across it.
Yeah. Yeah. It's the area. It's a watershed area. Your blood flow to this area is very poor. You have a couple of nutrient arteries that come down and provide blood flow to the metatarsals. And in this area, you have one region that's coming in and not getting enough to that base, and then you have another region coming in, and with the injury, it gets shut off or broken through,
lacerated,
and you get a hematoma in there, and spacing it out even further. You have the traction from the peroneals. I mean,
so think of the soft tissue component of that blood flow coming in from the tendon attachment, and then the large nutrient artery coming down from the shaft, and they're meeting in the middle. It's in similar ways. Watershed injuries of the Achilles are the same problem.
Exactly.
In the Achilles tendon in the back of the heel, you have blood flow coming up from the Achilles attachment from the calcaneus and then down from the muscle, and you've got this area of relative avascularity, 3 to 6 centimeters above the attachment, and that's your watershed. We call that the watershed of the Achilles, where Achilles ruptures usually happen. So there's a reason why these things are happening from a blood flow standpoint, and why you end up having healing problems after the fact. Yeah. So if we attach this with a screw and we suck those tissues back together, we're giving it the best chance for that nutrient artery to heal and for blood flow to be restored to the area. Especially, sometimes when these are neglected, when they're 6 to 8 weeks down the line.
Yeah, here's a non-union right here.
You've got to carve that tissue out and then sometimes bone graft it.
I do try to put bone grafts in these. If
I would recommend it, definitely. Just so you don't lose length.
So conservative treatment options, like I said, I'm very hesitant on these, and I tell my patients this up front. Look, there's a high chance of this becoming a chronic problem, a non-union, a delayed union, whatever you want to call it. But I'll have them in a boot. I'll have them off weight bearing. I don't have them walk on it. I don't know what your protocol for.
Yeah, I like the knee scooters. I like the tall boots though. I really don't use those short boots. I think they're too unstable. Or a cast. I think a cast is great. And these would maybe be patients who
healthy.
Yeah, maybe young, healthy non-smokers.
Yeah.
Or folks who just are horrible candidates.
Surgery candidates.
So if they've just got tremendous PV, peripheral vascular disease, they've got diabetes and peripheral vascular disease, and maybe they're also a smoker, that's going to be a really tough situation.
You're talking about fixing one problem, and then with their past medical history,
potentially creating a new one. Yeah. I mean, you might be causing a wound that would never heal. Yeah. So you got to do your basics. Your basics would be get blood flow studies, maybe consult with vascular, figure out where they're at. And if they're still a candidate, then I would still recommend, putting a screw across it, even if you do it percutaneously.
Yeah.
You don't need to make a big incision with this.
Luckily, these are fairly straightforward when you do the single screw method.
That the angle to approach for that single screw is tough, though.
It's real tight.
Yeah. That's one of the most frustrating I think that's one of the most frustrating screw throws in the human body.
It is so frustrating. It's Dr. G, like, that's nail on the head.
These make it look easy because these are perfectly placed. These are lightsaber placed.
I had to search hard for these.
Yes, because they're not easy.
So what Dr. D is saying is when we throw that screw, and I don't know if you do cannulated or not. I do cannulated for these.
I do cannulated because just getting the the guide wire in there is hard enough.
Yeah, the old school method was a solid screw, which was,
really tough to do.
Yeah. So what happens is I tell patients this up front when they're booked for surgery. I'm going to attempt to throw a single screw across there. I give it a solid 15 minutes of me fiddling around, and most of the time I'm successful, which is wonderful. Yeah. The times I'm not successful, rather than drilling out their fifth metatarsal shaft, I'll open it up and I'll put a nice hook plate across there.
Right.
But what happens is, and this shows it like it has tons of space, but what happens is we try to throw a K-wire down the shaft of this. And the shaft is bowed, right? So that's one problem. So you think you got it
bowed in the wrong direction.
Yeah, you got it. Yeah, you're thinking I can throw it like this. No, you got to throw it. Right down the shaft, like towards the fifth metatarsal, neck and head. So you put that K-wire in there, and you're like, oh, I think I got it. And then you get your ladder. You're like, oh, I'm towards the dorsal cortex. I'm towards the plantar cortex. I'm not, and you kind of run it through.
You can even do it with fluoroscopy live and still struggle with this because you've got soft tissue that's constantly banging into the drill.
Yeah.
It's
you're hugging the foot. You're pressed up against it. If you're not pressed up against it, you're definitely going to miss.
Yeah.
And
it's easy to whiff.
Now they have new guides and stuff for them, which have made it a lot easier for us. Have you seen those where they have like the little angulation guides where it's going to hit the distal tip, and it's like, I think it's like a 0.5 or a 1 centimeter difference or something like that, so it's going to be just anterior to that tip. Super simple, and
those are pretty cool.
It makes it a lot easier, but still, all guides aside, it's still a difficult.
It's a challenging throw.
So what happens when, and that's for when they're nice and they're not displaced or there's not large gapping. That's what the ideal situation's for. When there's large gapping, if there's a chronic nature to them, if there's a non-union to them, then we talk about doing plates and hook plates and screws and staples and all that fun stuff. I'm a hook plate person. I don't like the staples.
Totally. I would do the hook plates over staples any day. And you got a nice picture in the middle there of an unfortunate screw throw.
Yeah. They got compression across it, but like we said, they're not pretty. Yeah. If it gave compression, and as you can see,
the enemy of good is better.
Look. So what we're seeing, top view is decent, right? That's your AP or your medial oblique. And you're seeing it's a decent throw. It's not the ideal. Ideal would be more down the shaft, right? And a little bit longer screw. And a larger screw too. Right. I usually use like a 4, 5, 5.0, 5.5 sometimes, depending on the size of the person.
Yep.
And we try to do a long screw down the shaft.
Kevin Durant had that injury.
Yeah, like this. This is an ideal screw.
Yep, that's a great one.
So
KD had. He must have had like a 5.5. His feet are so big. He's got like size 15, 16. Bolt. Yeah, I'd love it if all of my fifth met fractures were Kevin Durant sized, because, geez, you'd have bigger anatomy. It's usually this little old lady with this tiny little fifth metatarsal, and you're trying to, how am I going to get that screw in there?
But yeah,
But you're right. That's where the hook plates are great. You have to make a bigger incision. Yeah, you got to dissect all that out, but the hook plates are awesome.
Yeah, and sometimes while you're in there, what I do is I'll kind of curate out all that hematoma and kind of cause like a little bit of bleeding on both sides of the bone where the nice healthy bleeding bone still lies, and then I'll pack it with bone chips or allograft or whatever I have available, and I'll get that compression across there so there's a solid bony bridge from one bone to the other. From one end of that bone to the other end of that bone.
Right.
And
so you've got a lag screw there that's causing compression, and then the rest of the plate is really a buttress plate.
Yeah. And a lot of these new plates, I know the one that I use, I put these distal screws in after I get that compression across there. So I'll do this compression, I'll put this screw in there, and there's a little guide or a little jig that compresses that even further, and then I'll put my locking screws across there.
2.7s? Those are pretty small.
Yeah, 2.7, 3.0. I think these are 3.5s right here, but if you put if you do multiple small screws.
And those are locking.
These are locking. Yeah. I typically do locking for these.
Which is a nice construct.
Yeah. The only one that you're not doing locking is that lag screw.
Right. Yep.
Yeah. But yeah, simple. I'm not a big fan of the staples. I think they're well for certain parts of the body, for certain foot problems also. But I think you're better off doing these hook plates or straight plates.
I've seen too many non-unions with them. Yeah. Chuck Norris approves.
But yeah, I mean, recovery is just like any type of surgery, non-weight bearing. You're in a boot or a cast or a splint or whatever. Knee scooter crutches. I typically have them non-weight bearing for about 6 weeks. I don't know what your protocol is.
Yeah, I like the taller boots.
Yeah.
I try to use the knee scooters. I think external bone stimulators are great for this if you can get it covered. A lot of the insurers are paying for them right off the bat because they understand that Jones fractures are.
Yeah, your talus and your Jones fractures are known to be at risk for non-unions.
Right. They'd rather pay for that than pay for a second surgery.
Yeah,
which is smart. Second surgery is always going to be more expensive.
I'm a big fan of throwing whatever you can to get this to heal. And bone stimulators are phenomenal. Very ininvasive. I mean, you literally just stick it to the top of your foot and turn it on. Yeah,
the Exogen one that I like that is ultrasound. It's 20 minutes a day. Yeah. It's not asking a lot of the patient, so yeah, those are great.
And if you don't do it, there's a timer on there and let us know. So
if the patients aren't using it, yes, it monitors that, so then you can document that in the chart that the patient's been naughty. Yep. But most people are really highly motivated when your grandpa plays swag ain't. Oh, that's beautiful. I have seen some really, really pimped out crutches in my day. I had one teenager I did some reconstruction on, and her mom pimped out the entire crutch with both sides with rhinestones. It was hysterical.
Yeah, I've seen boots and casts like that.
Man, hundreds and hundreds of them glued onto her crutches. It was impressive.
One guy in Houston back when I was in training. He had a purple cast because he was a Saints fan, right? Saints purple.
Yeah.
Right?
Well, I think
He's from New Orleans, but I was in Houston at the time, and
he's a big Mardi Gras fan.
And and then he bedazzled, or someone bedazzled, the fleur-de-lis on the side of the cast. Nice. It was perfect.
If I had my druthers, I would wrap everybody in blue and gold casting material and make everybody a Notre Dame fan. So my Irish right here.
Well, anything else? Did I miss anything?
No, I think that was a great one for St. Paddy's Day, where everybody's Irish. So if you have questions, comments, please leave them in our YouTube feed, and listen to us on Spotify and Apple and wherever you find your favorite podcasts. Tell your friends. I think we've established a pretty good collection. We've got 16, I think, episodes.
Yeah, I think we're
cranking away. So we're going to start expanding out and doing some other things, but I think we've got a nice collection of good information about very common problems that we see in the office every day. So thanks again, Dr. Hussain, and thanks again for joining us. And we are the PODdoctors, and we will see you next time.